Hello, and welcome to today's episode on peak flow. The peak expiratory flow is the maximum speed of expiration measured with a peak flow meter in liters per minute. There are several terms that need an explanation. They are as follows. Forced vital capacity is the maximum volume expirated after a maximum inspiration measured in liters. FEV1 is the forced expiration volume in the first second after a maximum inspiration. FEV 1% is the relationship between forced vital capacity and forced expiration volume 1. FEF 25 to 75% is the forced expiratory flow, the flow or speed of the amount of air in the middle part of the forced expiration. Peak expiratory flow is maximum flow measured at the maximum forced expiration. Vital capacity is the volume change at the mouth between the position of full inspiration and complete expiration as measured with a handheld spirometer. If you want to use the measurements in the clinic, we help you with the normal values for women and for men. Values for children can be found online. It is used to measure a person's ability to exhale. It measures the airflow through the bronchi and therefore the degree of obstruction in the airway. It is measured in units of liter per minute. This is the device that we used in our clinic. There are a number of non-equivalent scales used to measure this, for example, the Wright scale, the UU scale, and so on. The peak flow is here presented in 12 normal Danish males and 18 females between 20 and 40 years of age on a sustained note. They are measured with the aerophone. Note that the sample used are all singers. Please note that in brain damaged clients, the relation between peak flow and voice parameters is low. We have presented this in German in 1995 and updated it in 2016 in English. When it comes to professional singers, it was interesting to see that statistically, the peak flow individually were rather stable. The peak flow measurements show normal lung capacity. Statistical analysis suggests no correlation to voice or hearing. In the first study, aerodynamic parameters were measured with Aerophone 2. They included peak flow, and they could document that the laryngeal aerodynamic parameters can be used objectively to follow patients longitudinally after operation. In the second study, the question that is underlined in this paper is of interest. The conclusion is that the results are dependent on the circumstances under which the physician is monitoring. Vibration system complexity and asymmetry do not have a simple proportional relationship. The pitch frequency is mainly affected by asymmetric structures of the vocal folds, whereas the impact of subglottal pressure is relatively small. In Phoniatrics 1 2020, there is a presentation in real time of the supraglottic shape in airflow. Feel free to look them up. Thank you for watching, and we'll see you in the next one.